Before we get started, this is part 2 of our conversation. If you haven't listened to part 1 yet, I recommend going back to catch up. Otherwise, let's dive right in. I'll tell you a story that was one of the events that led me to seek a different practice model. And I was in private practice, employed, and an MA said, "Can I add this patient onto your schedule today?" And she said, "It'll be really quick. It's just a prediabetes." And I was in a rush, and I didn't really think. I just said, "Fine, whatever. Add the patient to my schedule." So I go in, and it was an 18-year-old woman with prediabetes and PCOS, struggling with obesity. And an hour later, I walk out of the office visit, and I said, "Thank you for adding that patient to my schedule. She really needed my help. But don't you ever tell me that it's just anything, because this is my patient, and I have the incredible privilege to change the trajectory of her life and her metabolic health. And it's never just anything." And she was very taken aback, but I think it taught her a lot about me. But more importantly, it taught me a lot about me and how I was going to struggle in a system where I only had 5 to 10 minutes with my patients. And in order for me to, I liked that about myself. You know, I liked that I loved my patient so much. And I liked that I believed that I had this crazy confidence that my actions could actually change something. I worry that in a setting where many doctors kind of have that passion beaten out of them in a productivity-based setting, that we're losing that extreme ownership that I think is valuable to both physicians and patients.
Oh, I think it's gone. I absolutely agree with you. I think it's not my patient anymore. It's our system's patient. And however the system sees, she needs or he needs an educator, they go to the educator. If the system doesn't seem they need one, maybe they don't get one. And that system is maybe the health care provider system along with the insurance system. I mean, that has so much play, in what we do and how we spend our time. And I don't feel like, early in my own life, I felt I had a doctor who, if something happened to me, would show up at my bedside and direct my care. I certainly don't feel that anymore. I'm part of a system, and somebody will show up, maybe, if I can get to the right bed, and direct my care, and maybe better in some ways, not so much on what I might need, but what somebody my age, my demographics should have. I just went to a doctor, in a big system, and it was my first Medicare checkup, and it didn't involve really anything about me. It was about, I needed to hear about falling, and I needed to hear about, clutter, and am I depressed? There never got to be a time where I said, "Here's my concern." Or here's what I need. It was, you're this age, this is what you need.
Yeah, I looked at this graph recently, and now there's all these EMR checkboxes, right? And there's like these well visits and all of these things, and the doctor's kind of more focused on the computer than the patient because of all of this EMR clutter. And so I saw this graph, and it tracked the cost of healthcare, and there was another graph that tracked the percentage of employed physicians versus non-employed physicians over time. It was like 20% in the 80s and 90s. Now it's closer to 80% of employed physicians, and medical costs. And they all were the same line. They all went up exponentially over time. But there were two time points that you see a kind of a exponential shift. And one was when EMR became required. Mm-hmm. And the other was when HIPAA was implemented in 96. So I thought it was just fascinating that these things that we are told improve efficiency seem to be the turning points of when things just seem to get worse from a cost perspective, at least.
Mm-hmm. Yeah. Well, I mean, cost, it's mind-boggling, right? I mean, just kind of experiencing it personally, I just look at how appalled I am with all my coverage and still some of my copays and some of the denials where I still need it no matter what. And certainly, for my husband as well. And we're able to afford it. But I mean, at some point, it's not affordable for people. And in the old days, you might have been able to get more from the system than you can now. I mean, now, there's just too many boxes you got to fit in to be able to get approval.
Yeah. And the ability to collect data is just insane as well.
Yeah.
So I'm curious, you gave this talk about the feminization of endocrinology, and I would love to kind of dig into that because you mentioned that medicine was mostly men. Maybe this field was a little bit more women than other fields, but how have you seen that change, and what effects have you seen, and what do you predict for the future?
Well, I think things are better. Certainly when I personally, and this got me interested, negotiated my first contract. I guess I didn't realize that it was a negotiation, and that what I was willing to take might not be the same as what the next guy in my division with the same titles might be willing to take. And after my second pregnancy, I, for the first time, was home for 3 months because I had finished my fellowship and I didn't have a job yet. When they offered me this part-time job, it was just ideal. But I would have, my husband said, don't go there and tell them you'll give them money for you to work. Be sure you get a salary. But I took a really ridiculous salary. And then that sets the goal, as you go on. That first negotiation you do is so critical. And nobody told me, and I just didn't know. And then when I went to full-time, they wanted to kind of take that as the baseline and just convert it. And that's when I realized, no way, I need parity. And it was a big struggle. And for a couple of years, I didn't have parity to my male counterparts at the exact same level I was at. And women do this all the time, right? We're not great negotiators. We're not that mindset of walking in and saying, I'm worth whatever, and you pay me this or I walk. It's, oh, really? Could I get that much? Yeah. So we have to, and then I spent time helping other women with that first negotiation and, getting parity. But, up until that time I gave that talk, which was probably about 5-6 years ago, we were significantly underpaid as women in endocrinology. It was about 80 something cents on the dollar. And although it was shifting to all those older men leaving the field and the fellowship bringing in women, it took some time, and I'm not sure it's completely at parity, but it certainly has gotten a lot better. And then it's not just parity on pay, but parity on how much, who's got that half day off to go through all your charts or develop your slide deck that you need to teach the residents. So it's, it really has to be equal. And of course, in an academic center, it's a little bit more difficult because if you've got grants, you're at a different level. And if you're, tenured on the tenure track, it's different. And then you, of course, saw more women going not on the tenure track, but on the clinical track, where the workload, was more, more given to women than to men. So, kind of lots of groups were looking at this and coming up with data. So, it's been, I think, a concerted effort on all of our part to be sure our dollar is a dollar, whether you're a man or a woman, and that, the expectations are matched to what you're really delivering to your system. And I think it's better, but it may never be completely on parity.
And I think in addition to pay, the promotion to
Right.
the number of women that are deans or chairs of departments or high levels in academics are just so much fewer than men. And I think in endocrinology, I think we have seen more as the field becomes feminized. Hopefully we see more women in those higher positions. But when you look at the percentage of women in the field compared to the percentage of women in those leadership positions, you can see that there's a big gap there.
Absolutely. I think you can look at podiums, publications, deans, division heads, department chairs. There's still fewer women than you would expect. And, in part, we have children, we want to spend some time with our children. It's hard. It's a reality. And how we get that mommy track, and it's not permanent. It's not a permanent track. I mean, I had a mommy mindset for probably the first 5 years of my career. And, I had a grant. I was doing some, novel basic research in, a far off field of ovarian failure in women with galactosemia. So, which I think now has become a great question on most of the boards of what causes primary ovarian failure in women. But but it was a real struggle. I had to I was nursing through part of it. I can remember, filling out some of my grant application, while I was nursing one of my sons at the same time. So it's hard. And men will point out, you weren't there. You were on maternity leave or whatever. But we've got to figure out some way. And I think having paternity leave is a great idea to let those guys experience the same thing and, realize that it's a reality that is here for a short period of time and you don't want to miss it. But, there's been a lot. And I always go back to that internship evaluation that I had for a woman. I remember when I got my first NIH grant, I called the grant manager at the NIH to be sure there wasn't a mistake. Did I really get this grant? And she said to me, I don't know who she was. She said, Dr. Kaufman, does it have your name on the application? I said, yes. She said, does it say you've been funded? I said, yes. She said, why would you think that's a mistake? Why do women think that? And no man has ever called me.
It's that imposter syndrome that...
Right.
That culturally, yeah.
And I do want to say, even in outside society, so I was the second woman president of the ADA in 2003. The ADA was founded in 1940 something. And, there's still, for the number of women in endocrinology, have not at all been the number of women presidents that there should be.
Yeah. I think the imposter syndrome for women is we have too much of it. And then there's the contrary. Sometimes men have way too much confidence when in saying things that are actually inaccurate. And that's not true for all men. I know some very humble men who have experienced imposter syndrome as well. But I do think it is something that kind of pervades women, especially women with careers. Now, 70% or perhaps even more than that of endocrinology fellows are women. And as you know, endocrinology is a very, very poorly reimbursed specialty. At Medscape, it made me, I don't know why it made me laugh a little bit. It's either laughing or crying, I guess. But endocrinology was the lowest paying medical specialty in the entire list, like lower than internal medicine, pediatrics, with our 5 to 6 years of training that is on par with our cardiology colleagues and orthopedics colleagues.
Right.
We're the lowest. Do you think, and I know there are a lot of different forces going into that reimbursement structure, but there is this cultural or sociologic concept that as a profession becomes feminized or more women go into a profession, it is devalued or not seen as complex or not worth as much pay. Do you think that is hurting us?
I do. And, this was a main thrust of the talk I gave, was that it's kind of a cycle, right? It's, there are lots of opportunities. It's an exciting field. Women gravitate, and maybe in part they gravitate because there's not a procedure that takes, the skill that we think a surgeon, and of course, surgery is still much more male dominated than any of the other fields. Women gravitate, women are willing to take less because of this mommy track or whatever it may be. Therefore, we pay less, then it's easier for a woman to get in there, and it just keeps cycling on itself. So there is a big concern. And, I think we can see, one could argue we don't value children the way we should in this country. Therefore, pediatricians get paid less than internists for the same, maybe even more complicated, prevention and all the other issues that pediatrics can face. Obstetrics and gynecology, at least they've got some really significant procedures, but, it's always in the hierarchy where they're placed kind of next to peds because they're taking care of women. And then, once this is what happened with teaching, right? The big example in the Western world was teaching, where it was completely male dominated. And once women got into it and became a woman dominated, it's not only payment, but it's stature in our world changed, to the negative as well. And, I think we still look at, a man who wants to become a third grade teacher. What's wrong with him? So it's kind of sad because it does affect men in a lot of ways in addition. And maybe a man who would love to be an endocrinologist can't justify in his own mind doing that because the pay is so low. So we've got to figure out a way to have parity. And I wish I had some answers, but I don't think I do, whether we need a procedure. We can't just manufacture a procedure. Our cognitive involvement is huge. Can anybody else recall, the hypothalamic pituitary adrenal axis? It's just very, complicated stuff that we deal with, and yet we're not reimbursed for that cognitive load that we bear.
I think the insulin pumps are the craziest example with no CPT code, unless you know of one that exists. Whereas, you can bill for a CGM, but you can't bill to interpret an insulin pump download. That one I find baffling.
It's because that alone is just about insulin delivery, and without looking at the matching glucose, what can you actually really do? So, but I agree with you. A lot of it doesn't make sense.
Yeah, like an EKG, even if you don't get reimbursed a lot for it, at least it's recognized as work being done.
Right.
I have this thought about, a lot of women are going into endocrinology. A lot more applicants are women, and mostly from what I was reading, Elaine Pelly has a great article that I'll send you after this on the feminization of endocrinology. But she talks about how we're not gaining more endocrinology fellows because more women are applying for endocrinology. It's because fewer men are. So all numbers are down. Fewer women are applying for fellowship and men. It's just the men are far less. But I wonder if when we think about endocrinology in the future, if perhaps pay parity is one thing to think about, but perhaps it's not everything, because there are other reasons that we choose our specialty that aren't pay. And as a mom, not being stuck in the OR in the middle of the night is good, right? And so my husband's an intensivist, and I loved ICU too, but I thought that would be quite challenging on our children if we're both ICU docs gone at all kinds of hours of the day, and I would like to raise my own children. And so I think that perhaps thinking about the intangibles, like what can we do in endocrinology to support the women coming in to the field, because we know they are, in ways that, because we are not going to overnight change CMS numbers and insurance reimbursement, although, we would love to with time. But perhaps it's more that we support each other, create environments where we give women grace postpartum and support them when they're breastfeeding, because I remember that being extremely challenging as a fellow. Or we cover for each other when, we have an engagement at our children's school, or we have to take our child to the pediatrician, or the things that we know we're going to be struggling with from a time perspective, a clinical perspective, but also a mom guilt perspective too, those responsibilities that we don't want to necessarily give to others. What do you think about that?
Well, there was a movement, I don't know, maybe it was 15, 20 years ago, about job sharing, where, you would have a pool of people, maybe 2, 3, maybe more people who were not full-time, and that could have more flexibility in negotiating, what clinics they would do and when, and of course, maybe not so much my own patient, but our little consortium's patients, and that they could, really work together. I don't think it took off because, again, it meant much less reimbursement. Everybody's going to be the equivalent of a full FTE or 1.5 FTEs, but you could maybe do it, in a group of women in a practice. And just, have really good scheduling where, if I need to have a clinic from 4 to 6 one day because I need to take off 2 to 4, that there's that kind of flexibility. I think you're right. The hardest thing is walking out of that hospital in the middle of the day because your kid's going to be singing on some stage somewhere, and then not wanting to go back because everybody else is going to go to the ice cream place and you be the only mom. And, so I do think some kind of greater support. And if you're not a mom, just maybe there's other things you want to do, more travel and things like that. One of the things that pediatric endocrinologists do a lot of is diabetes camps. And there's a Turner's camp, where that's an opportunity for some of them. You can bring your own family and, really give back. You get a sense of, I'm here. They really need somebody. It's not that easy to find people. or international work if people really like that. In the pediatric world, we have a school that goes around the world teaching often not endocrinologists, but pediatricians who want to concentrate on caring for the diabetes pediatric population, maybe in Zimbabwe, where there aren't enough there are not enough peds endocrinologists in the US, let alone, outside. So some of those maybe perks built into some of the systems where, particularly some of the hospitals, have community give back that they have to do so they could pick up a camp and, help the faculty man the camp in a more equitable way.
I think so. I think some of these very humanizing experiences are what a lot of us are craving. And my practice, we've created a space that we're 3 women endocrinologists, and we all have very similar philosophies on how we want to take care of patients and how we want to live our lives. And so it makes it very nice and easy to collaborate together to ensure that our patients are taken care of and our families are taken care of. But I do think that there might be ways in endocrinology creating solutions like what we have, or creating interesting opportunities, because I think what happens is people don't want to go into a specialty where they're on a hamster wheel, they're a cog in a wheel, they're not getting paid very much to do it. I think it's 25% of women leave medicine within 6 years of training, or at least go part-time. And in a field where you're making very little, it becomes this balance of, well, is it even worth it? I kind of went through this too, because when I was in practice, I wasn't earning enough, and I was in private practice working full time. It still didn't feel like I was earning enough to justify, one, the exorbitant cost of childcare. We had to have 2 nannies, and just the cost, the actual financial cost of supporting my career, as well as the opportunity cost to myself and my family and our overall health. But if we can give back in some of those ways, where maybe women aren't feeling like they're sacrificing as much, even if the pay stays the same, perhaps that's the way to get more people into this field, because I just am trying to find solutions to make this field attractive to people, because we have such a shortage of endocrinologists that we've got to find a way to enhance access to our expertise.
Right. Well, I think it might be kind of individually based, but I like the whole concept of, how can we expand further the benefits of being an endocrinologist? And to me, I spent 30 years in our diabetes camp in Southern California. Do I look like I like camping to anybody? Just not my idea of fun. I don't like dirt, and I certainly don't like the wilderness. But I had the opportunity. The first year I went, I was still nursing one of my kids. And you get to, first of all, experience diabetes in a way that's just incomparable. And as well, I was always able to bring my whole family. My husband's a general pediatrician, so he would come as well. And my kids grew up there. They became counselors when they were old enough. And, it was a great family experience. My hospital does a fair amount of international medicine. And that was another thing where, it wasn't just because you were an endocrinologist, but early on in my career, my hospital adopted the Children's Hospital of Ulaanbaatar. And so a bunch of us went, the adolescent medicine doctor, the ENT guys, hematologists, and we were there teaching for a while and seeing patients. Those kind of experiences are phenomenal. And I would suggest maybe even, meaningful to anybody for sure, but to see what it's like someplace else. There's just so many opportunities, and particularly rife for endocrine. Now, it's maybe a little different if you're a plastic surgeon and go and you could fix, cleft palate and walk out. This is a little bit more of a commitment because we can't fix the diabetes, right? We can only help somebody there stabilize and manage them through the years. So I still am in contact with a number of these. I mean, I've been to Bangladesh, Ethiopia, Ecuador. I mean, lots of places where you make an impact and relationships that kind of last a long time.
I think you've said so many things in this interview that just demonstrate, I know burnout is a big issue in moral injury, but just the dynamic nature of a career in medicine and all of the different opportunities to advocate for people that we have the privilege to have. And in your career, you've done so many different types of things and juggled so many things that I find that so inspiring, because I think we forget now in this kind of rat race type medicine that we're living in that we actually can do something. We actually can advocate for our patients in front of us in other places all over the world. With our voice, we can really do something. So I am in awe of you and so grateful for your time. As we sort of wrap up, I was just wondering, is there anything that you would want to leave our audience with, or anything that you would want to say to women endocrinologists or people considering this field?
Yeah, I mean, I would. I think in my own career, I early on viewed it kind of like as a journey that I wasn't going to necessarily, I mean, even in academics, you start in, however much time you're in the lab versus in the clinic versus teaching. I mean, all that can fluctuate and change. And if you find a passion somewhere, or, an opportunity to take it. And don't say, well, no, I have to see my patients, 30 hours a week or whatever. Negotiate that, I want to be in an international framework and I want some kind, whatever it is. And I just feel like I've had a zillion different opportunities in my career. And mainly because I was willing to step out of a comfort zone, knowing that, sure, I can go to Ethiopia. Diabetes isn't going to be that much different in Ethiopia. How I treat it, they're still on RNN, but it's a challenge. And then while you're there, you're making a difference. But that what you walk away with is even infinitely more than what you left. And so, view it as a journey. I took a big leap to go into industry and then change, it from a big company to a startup, making the first fully implanted sensor, and just, be on a journey. Don't say I made my destination. I mean, look what you're doing. I mean, this is phenomenal as well, right? You took an opportunity, you took a risk, a challenge. And it's just exciting. It keeps that burnout gone.
Yeah. I certainly don't experience burnout, and I'm so grateful for that. It brings me to something that I think about a lot, and just because it's customary doesn't make it right, and certainly doesn't make it right for you. And I think just that's great advice, to seek different opportunities, even if they seem crazy or different, or, if it seems interesting to you, or it could help grow your mind or grow your passion or grow your expertise. Just do it. You only have one life to live. And as an endocrinologist, you always have a job. You're always hireable. So I think that a lot of physicians have been on a path, right? You go to high school, college, med school, residency, and it's scary to jump off that path and do something different, but it can be the most exciting, rewarding, biggest mistake, but you always learn from something sometimes. But usually, you're smart enough to get this far. You're probably not going to make that big of a mistake at this phase.
And if you do, keep on the journey and, keep
pivot.
moving forward, right? And find the next thing that you're interested in. And realize, you said it many times, and it kind of gives me the shivers. What better job than being a doctor? The way we can impact in people's lives and how they impact on our life. It's just unequaled, I think.
Yeah, it is the best career in the world. Certainly has its challenges, but I wouldn't trade it for the world. And it certainly sounds like we're in the same boat on that. Well, Fran, thank you so very much for your time.